Discord link in the chat once more if you guys can join and answer the questions. We've got quite a few SBAs, but also we can see who's in the chat. So we've got 25 people on VVox so far, and 85% of you are in fourth year, which is great. Just to let you know, as Anush said, we've got some finalists joining just as last minute revision before our finals in a month's time. So don't be alarmed if you get lots of quick, speedy answers and people who seem to know a lot. So we wanted to do antibiotics because we think it's a topic that's generally really, really badly taught at UCL, and they often leave it to you guys to rote learn, and we hate rote learning. So what we thought is to devise a way for you guys to sort of get a general understanding of antibiotics and be introduced to the different class and things, so you can begin to spot patterns and make it much more sort of thinking logically about antibiotics rather than just remembering nice guidelines. So in this talk, we split antibiotics into three main types by their mechanism. So whether they target the cell wall, whether they target protein synthesis, or just the rest of them, which tend to either affect DNA synthesis or a few oddball mechanisms. And also we talk about whether antibiotics are bactericidal or bacteriostatic. Can anyone put in the chat what the difference is between bactericidal antibiotics and bacteriostatic antibiotics? And perhaps for you finalists, why does it matter for us clinically? Okay, very good thought. That's on the clinical sort of side of things. Very good. Let's start with the definition. Very good, Nadia. So bactericidal will kill the bacteria, whereas bacteriostatic, if you're thinking about something that is static, so not in motion, it's just stopping replication. In terms of the implication of that clinically, is that bacteriostatic antibiotics, they stop bacteria from replicating and getting bigger and spreading infection, but your body's immune system still has to kick in to finish it off. Okay, so bacteriostatic antibiotics aren't that useful in patients who are immunocompromised if they don't have a complete immune system to finish things off. And another frame of thought, in particularly tough infections to treat, say infective endocarditis, you want to make sure that you're giving antibiotics that are bactericidal. So we want to give more hard-hitting antibiotics. So those are the main reasons we think about whether antibiotics are bactericidal or bacteriostatic. Okay, right. So this is how we're going to cover the lecture today. We're going to introduce you to the main class of antibiotics with some examples. We'll talk about their main roles in common infections and important side effects, because that they love to test side effects. And then we've got some useful summaries at the end and SBAs dotted throughout. One of the things I mentioned about is trying to think about antibiotics as a sort of characteristic, not just rote learning, thinking about what each class of antibiotic is good for and how they behave. So we've thought a really good way of thinking about this is by considering them in the realm of the Avengers, your different types of heroes. So we'll introduce each class of antibiotic as a different Avengers or Marvel hero. So hopefully that makes things a bit easier for you guys to remember. So let's start off with the cell wall antibiotics. First of all, they're all bactericidal, because if a bacteria doesn't have a cell wall, it can't live. And generally, antibiotics against cell walls are good against gram-positive bacteria, because gram-negative bacteria have a special adaptation to their cell wall that makes it harder to target. And I'll hand over to Anush to introduce you to our main first heroes.
How do I take control? God, I haven't been on Teams for ages. Right, I can. A few of you are probably like hesitating and like wondering why we've gone with this weird theme, but trust us, it works. So I guess, so the cell wall antibiotics, we're going to talk about probably the three biggest groups of antibiotics that you'll see used in hospitals across the country. Penicillin's the single most used group of antibiotics. Also possibly the most effective commonly used group of antibiotics. Cephalosporins are also very good, and carbapenems, which are kind of like our nukes, that work against lots of things, are quite toxic but also very effective. And then James will briefly talk about glycopeptides, which are quite specialist, narrow spectrum antibiotics, but are really good for specific circumstances that I'm sure he'll mention in a minute. So if you'll humor me for a bit, Actually, no, we'll start with an SBA first. So a 19-year-old developed swelling around the mouth, neck, and widespread hives following their first dose of treatment for a skin infection. What is the single best investigation to confirm this type of reaction?
The poll is up on Vvox, so put your answers through there.
And those of you that are feeling smart, what exact antibiotic is the likeliest one that has been used to treat this skin infection? That you can put in the chat.
We've got half of you responding now, so we'll wait a little bit longer. Got a nice spread of answers, so that's good.
You can have 20 seconds. So the other question was what single antibiotic is, as per NICE guidance, would be used to treat this patient?
Okay, I've posted the spread of answers into the chat for you, Anush, and I will close the poll.
Excellent. Most of you are on the right page. No one has answered my bonus question, or my chat isn't working, which saddens me greatly. Okay, Nadia gets like a prize of something. You get the prize of some like instant gratification, because I can't physically give you anything else. So yeah, skin infection, first line treatment is flucloxacillin. We'll talk about why in a minute when we go through something a bit weird. But the diagnosis here is an anaphylactic reaction secondary to a penicillin. Serum tryptase following an anaphylactic reaction, if you do it in the hours following, you'll get a raised level, and that confirms that it was a true anaphylactic reaction. Good. Right, some minimal biochemistry, and I say minimal. This is the Betalactam Ring. You don't need to know that much about it. All you need to know is all three groups of beta-lactam antibiotics, so penicillins, cephalosporins, and carbopenems, have this ring within them, and this is intrinsic to their bacteria, to how they inhibit cell wall synthesis. People can be penicillin allergic, i.e. they're allergic to penicillins, or they can be allergic to the beta-lactam ring itself. And the cross-reactivity between penicillin allergy and cephalosporin allergy is around 1 in 10. So often someone who's had an anaphylactic reaction to penicillin will not be given cephalosporins either. But if you really need to, you might do some allergy testing or do it under controlled situations, because 9 out of 10 people can still take the cephalosporin. Oh, look, I preempted my own slide. So that's just one thing to keep note of. Right, we're going to humor me for a bit. We're going to talk about the history of antibiotics, and trust me when I tell you this will help you remember what, like, the spectrum of action. So penicillin was like the first antibiotic that like we created, that Alexander Fleming accidentally grew from Penicillium, which was a fungus. That you don't need to know about. Can anyone tell me what was, in terms of bacteria, what was like the prevailing infection at the time that penicillin was basically designed to like destroy? The clue is sore throats used to kill kids. Is there a link between severity of penicillin allergy? No, I don't think there is. Actually. Streptococcus, yes, absolutely. So strep throat was basically a huge problem, and penicillin was designed to eradicate strep throat. So it's very effective against streptococci. And strep throat itself at the time was very severe because we couldn't get on top of it, but also had lots and lots of complications. What are some complications of a streptococcal throat infection? Hi, someone has their hand up. Do you have a question?
No, sorry, that was accidental.
Oh, don't worry. What are some complications of streptococcal, strep throat? Yeah, so there are severe things. So rheumatic fever, and then also scarlet fever. But yeah, rheumatic fever back in the day was a big one. So yeah, strep throat, strep chest infections, pneumonia used to kill way more people than it does today. So they created Benpen, which is the original penicillin, which is an IV drug that worked well against all of these strep infections. The problem with Benpen is it was an IV drug, and yeah, strep throat and rheumatic fever were still very common in children. So they created an oral version of benzoyl penicillin called Pen-V. Again, we still use this today for strep infections that aren't resistant to it. Unfortunately, making it oral made it lose gram-negative cover. So problem number one. So this is like a quality improvement project. They basically kept making things, encountering problems, and then tried to solve the problems. A bit like how Iron Man designs his suits. So problem one is they needed an oral drug that is good against both gram-positive and gram-negative bacteria. So the solution. What is the most commonly used penicillin-based antibiotic that you've seen on the wards? Or actually not on the wards, in the community, across everything. Because on the wards, you're going to give me some rogue answer because everyone is resistant to everything. If you went to the GP and you had some kind of infection, what penicillin thing would you get? Amox, absolutely. So amoxicillin was an improvement on Pen-V, where they made an oral drug that has good gram-positive to cover the strep, and it has good gram-negative cover, so it's more broad spectrum. But then they encountered a problem in the second problem. Staph aureus is a common skin infection. It's a skin commensal and it can cause infections, and it's resistant to all of the penicillins thus far. Does anyone know why Staph aureus is resistant to most penicillins? Biochemically.
Beta-lactamase.
Excellent. Yeah, it intrinsically produces beta-lactamase. It hasn't adapted to produce beta-lactamase like a lot of resistant organisms have, but it's just intrinsically produces that enzyme and breaks it down. So again, we made an improvement. Does anyone know if we made a penicillin that is resistant to weak beta-lactamases? Does anyone know which penicillin that is? Again, you'll see it used a lot, and someone has already mentioned it in this lecture. So, coamoxiclav does have good activity, and it can have activity against Staph aureus, but coamoxiclav is much more broader spectrum, which means you're at increased risk of producing resistant organisms. If you know that you're targeting Staph aureus, there is a much less broad spectrum antibiotic that is basically amoxicillin but resistant to beta-lactamase without adding a beta-lactamase inhibitor.
First line for cellulitis.
It is first line for cellulitis. Fluclox, yeah. So Fluclox is a weaker is a weaker but beta-lactamase resistant penicillin that is effective against Staph aureus. And at this point, it's probably worth noting that when we talk about methicillin-resistant Staphylococcus aureus, so MRSA, what that means in a clinical context, because methicillin is not an antibiotic we use in clinical practice. We only use it in labs. If you have MRSA, that means you have Staph aureus that is resistant to Fluclox, and you have to use something other than Fluclox to treat it. But yeah, Problem number 2 was other bacteria were starting to become resistant to penicillins, and Fluclox wasn't strong enough to beat these. And you've already given me the answer to the next question, which is basically add a beta-lactamase inhibitor to the penicillin. So coamoxiclav is where you add clavulanic acid to amoxicillin, so it can be used against all of these resistant strains. Interestingly enough, it has a second added benefit. Not only does it now work against these new resistant strains, but it also gives it some anaerobic cover. I don't really know why. James, do you know why? No, neither of us know why. You don't need to know why, like, unless you're applying for SIT MRC path or whatever micro people SIT. So that's basically, those are like the 4 most important penicillins you need to know. The one thing I'll also mention is you might have heard of piptaz or tazocin, which is basically like a newer version of coamoxiclav. It's piperacillin plus tazobactam, so it's a penicillin plus a beta-lactamase inhibitor, and you use that in very severe infections, so like severe hospital-acquired pneumonias, neutropenic sepsis. It's like a stronger version of coamoxiclav that's newer and has less resistant organisms against it, unless you're in Liverpool like I am and everyone is resistant to it. Right, so modern day uses of penicillins. Skin infections, we've already said use Fluclox. Community acquired pneumonia, mild, what do we use? Again, we mentioned it earlier. It's just revision. Talker type. Amoxicillin, yeah. Severe community acquired pneumonia. So you're worried about some kind of mutated resistant strain. Coamox, excellent. And then lastly, strep throat, and it's definitely strep. And it's nothing else. And you want a narrow spectrum of action. Although James will counter this point, as I'm sure, yeah, you can use Pen V still. James will counter this point with the fact that Pen V is given 4 times a day, and giving kids antibiotics 4 times a day is a nightmare. So they might just give you Coamox, and just give you Amox.
Especially because if you've ever tried to taste Pen V, it's absolutely abhorrent. It's really disgusting. But yeah, that's a side point for when you go on to peds next year. So don't worry about that, 4th years.
I think James is just traumatized. He's probably taken Pen V or something. Right. Cephalosporins, less to know about than penicillins. IV only, although there's like, you can get cefalexin, which is like a fairly useless cephalosporin that's only used in the context of UTIs and pregnant people. That's oral, but basically on the whole, IV only. They're very old antibiotics. They're very reliable, massively broad spectrum, work gram positive, gram negative, very effective. What kind of infections have you heard us using cephalosporins in the context of? I mean, there's lots, but yeah, meningitis is the important one, and that's because it can cross the blood-brain barrier, which is actually not that common with a lot of antibiotics. Excellent. And then, yeah, you can use it in the context of kidney infections and like UTIs in pregnant people. You can use cefalexin, which is like a oral cephalosporin that we have now. Well, you don't really use it for that many things, but there's just a little tidbit of like information for finalists in case it comes up. I doubt it. Here's a cheat for you. There's lots of generations of cephalosporins. Look at the letter after the F to guess the generation. It's not going to come up, but if some consultant puts you on the spot, if it's an A, it's 1st gen. If it's U, it's 2nd gen. If it's T or O, it's 3rd gen. You don't need to know about it. And lastly, we'll talk briefly about carbopenems. Yeah, it's pretty self-explanatory. You only bring in the Hulk when the situation is really bad, and then the Hulk goes mad, and like there's not that much resistance to them, although it's increasing. And it's neurotoxic because Hulk get angry. So very neurotoxic, and people can start acting funny, although it's very rare actually, because we monitor people who are on these medications. I'm going to hand back to James to talk about glycopeptides briefly.
Sweet. So we think of glycopeptides like vancomycin as our Hawkeye. It's a very specialist agent. And the way it works is it goes into the cell wall and it disrupts them. So there's not as much resistance to it by breaking things down. And bacteria don't have an enzyme to break this down. It just gets put in their cell wall and screws it up. We think it's a specialist. It's very useful in specific conditions. So MRSA, when we know there's an antibiotic that's resistant to penicillins, and C. diff as well. But you won't see it too much in other conditions. And another useful thing is if you think about the arrow of Hawkeye that's going straight into the veins, it doesn't really get absorbed orally. So if you see vancomycin given for systemic infections, it's always given IV. However, can you think about when a poor oral absorption might actually be useful? What kind of infections would you see someone being given vancomycin PO? That was rapid. Well done, exactly. C. diff, well done, Matthew. So if you're thinking about C. diff infections which are in the gut, it's useful for an antibiotic to not be absorbed so it stays in the gut so it can target those bad bacteria. Does anyone know what side effects you worry about with vancomycin? It's very classic SBA fodder. You don't typically see it in real life because we manage it quite well, but there's a very big condition that's sort of almost pathognomic because it just gets linked so much with the SBA. Has anyone heard of red man syndrome? Ototoxicity, good shout. It does do that as well, and we'll talk about that later. But the one that's sort of almost unique to vancomycin is something called red man syndrome. So these are pictures of it. For final years, it's also known as erythroderma. But yes, they become red all over due to sort of massive histamine release. I've put in words here because sometimes question writers like to trick you, and instead of giving you pictures, they'll just describe it. So they may describe an intense pruritus, a widespread erythematous rash involving the whole upper body or whole body, and it's shortly after receiving IV antibiotics. And if you see either these pictures or these phrases in the context of antibiotics, think of vancomycin. You're absolutely right, though, Matthew. Vancomycin also does cause nephrotoxicity and ototoxicity. Okay. But yeah, it typically happens when we infuse the antibiotic really fast. So we don't see it that much now because we have guidelines about giving it at a specific rate. Onto a question. Oh, and here we go. There we go. Nephrotoxicity, ototoxicity, and rarely thrombophlebitis. Fine. Let's now go on to an SBA. About C. diff treatment, and I've put this here particularly for the final years because it's a change. There's been a change in guidance since we've last had fourth year. So see if you can answer this question.
I got this wrong when James sent it to me.
I think yes, Prina. I think quite a lot of things can cause a full-blown anaphylaxis, but I don't think necessarily a red man syndrome will then proceed into anaphylaxis. But as with most drugs, it can cause anaphylaxis. Okay. Great. We've got 7 answers so far. Give you another 15 seconds. Oh, we've got two front runners for the most popular answer, and one of them was the one that Anush put.
If you work on my ward, you would pick the wrong option, and it would be none of those.
Okay. Right, 5 more seconds, and I'm closing the polls. Oh, this is really close. I can see someone's flitting between 2 answers because the numbers keep on changing. Right, so let's close the polls. and post the answers. So the majority of you did go for the correct answer, which is fidaxomicin. But the second answer that was most popular was vancomycin and metronidazole, which I can completely understand because I think that's old guidance. But here we go. So let's go through the answer options. So high dose vancomycin, you don't really give by itself. So if you're getting to the point where you're giving high dose vancomycin, it's a severe infection where you want to pair it with another drug. Bezlotoxumab is mentioned on the NICE guidance, but it's mentioned specifically because they say it's not a cost-effective treatment. So never go for the monoclonal straight away. Vancomycin and metronidazole was the second most popular answer, and I can completely understand why. NICE guidance is to start vancomycin and metronidazole if it's a life-threatening infection or as a third-line antibiotic. In this case, I've mentioned specifically that she has normal observation, so it's not life-threatening, and we've only tried one treatment, which is vancomycin. So you'd want to try the second-line treatment, which is fidaxomicin. You definitely don't want to start tazocin because broad-spectrum antibiotics like tazocin are actually the ones that cause C. diff. So here's a nice summary of the NICE treatment for antibiotics. So in an acute presentation, you give oral vancomycin first line, second line is fidaxomicin, and like I said, if it's third line or life-threatening features, you give oral vanc and IV metronidazole, and that's when you give the higher dose of vancomycin. Oh God, Anush. Oh, that's terrible. Oh, it's just classic, isn't it? There's a different thing when it's recurrent. So if someone's been treated for C. diff, they've gone home and they come back a month later and they have C. diff again, then you've got to think about it differently. If it's within 12 weeks, i.e. within 3 months, it's likely the same bacteria. And if it didn't respond well to the vancomycin, it's probably not going to respond well to the same drug. So you'd give fidaxomicin in the second line treatment. However, if it was and they've come back later, then it's likely a different bug, a different type of C. diff or a different serotype. So therefore, you might as well, you're happy to try vanc or fidaxomicin because you don't think it's the same one that you tried treating earlier. The only other thing to think about is if they have 2 or more episodes, you can consider a fecal microbiota transplant, which is when you take a poo sample from someone else and then insert it so that you introduce healthy gut microbiota to make them more resistant to C. diff in the future. But it's obviously not a very appealing thought. Right, moving on, unless Anush wanted to say something.
I was just going to say, though, if this comes up in an OSCE, remember to say you would look at local guidance about the management of C. difficile within the trust, because there's different resistances wherever you're going to work. Even between like the free and the wet, they have different guidelines for things like this. So just remember that.
Yeah. So NICE for exams, but in OSCEs just say local guidelines. Then we're going on to the protein synthesis antibiotics, and these are mostly bacteriostatic, apart from aminoglycosides. Those are the sort of the odd one in the bunch, and they're generally quite broad spectrum because if you think about it, all bacteria need to make proteins. The difference with that and cell walls is that bacteria have different cell wall structures with the gram-positive and gram-negative ones. So introducing to you our next lot of heroes. We've got, from the Guardians of the Galaxy, we've got Gamora, who is our Macrolides, and we think that's because she's reliable and it's useful in penicillin allergies, and mostly she's green, so that made me think of GI side effects. Then for the big heart hitter, we've got Thor for aminoglycosides, because they're the ones that are bactericidal, right? But similarly to the Hulk, he does have serious side effects, so ototoxicity and nephrotoxicity. But aminoglycosides are one that we really use in serious infections like infective endocarditis. Interestingly, if this helps you remember why aminoglycosides are the one sort of protein synthesis antibiotic that actually kills them, is because instead of just stopping protein synthesis, they encourage the protein synthesis to happen, but introduce mutations. So not only are they not producing proteins, they're producing mutated proteins, which can screw up with function and kill them. And then finally, we've got tetracyclines as our fun Chris Pratt, who looks the part but isn't actually too helpful. But it's nice to think about him as useful in sort of dealing with alien infections, so like malaria, Lyme disease, the ones that are caused by parasites or sort of rogue tropical things. The tetracyclines can be quite useful for that.
To only slightly ruin your analogy, doxycycline is one of the most useful antibiotics you will ever come across. So
okay, but
to give it them some credit.
Okay, Chris Pratt is actually quite good. Fine. So we've talked about macrolides, and these are the ones that end in mycin. Okay, and they're a great alternative to penicillin. So pretty much every indication where penicillin is first line, if there's someone who's penicillin allergic, you'll probably go for a macrolide. Particularly in pregnancy, you'll go for erythromycin. But yes, so if in doubt, if someone's penicillin allergic and you would have given them penicillin, go for clarithromycin or erythromycin. They've got very good atypical cover in pneumonias. So therefore, in pneumonias where the curve score is say 3 to 5, you want to add in a macrolide to cover you for the atypicals. There are GI side effects, so they can often cause diarrhea or nausea and vomiting, hence Gomorrah being green. The one that that applies mostly to is erythromycin. All of them do cause this sort of gastric irritation, but erythromycin is actually very potent for it. So much so that in patients with diabetic gastroparesis, where the gut isn't really allowing motility, some people will be started on erythromycin to really get the gut going so they can actually have a sort of more normal digestive system. The only reason I mentioned diabetic gastroparesis is because it's come up in previous questions and in very rogue things that I've never seen before and thought, why the hell are they asking us about this? The important side effect to know about with this group is that they can cause QTc prolongation or QT prolongation. Why do we worry about QT prolongation? What's the sort of big adverse effect if someone has a really long QT? Very good. Torsade de pointe, which could then lead to ventricular fibrillation and therefore death. So you want to be really careful about starting macrolides in people who already have a prolonged QT, for example, if they have congenital long QT syndrome, or if they're on any other drugs that are known to increase QT, like antipsychotics, for example. Good. That's our macrolides. Let's go on to a question. This is a very mean question, so don't be worried if you're not sure where this is going if you're a fourth year. Final years, this is still a really challenging question. It's like a 4-step question. So see if you can put everything together and put your answers in.
Although, James, correct me if I'm wrong, we also realized last time that this could also be a 1-step question.
True. The picture helps, yeah. But if you get it in 1 step, see if you can try and get it via the 4 steps instead, just to improve your general knowledge.
Just to entertain the amount of time we spent making the question.
Make it feel worthwhile. Oh, we've got a few answers in. Speedy answerers who've probably gone down the 1 step.
Also, there is one answer that if you choose, I will cry. Just a heads up.
I really want to know what that answer is.
Next most appropriate investigation. Fine. I think you can figure it out.
Okay, fine. You'll be glad to know at the moment no one is disappointing you. Okay, 10 more seconds. You guys are doing very well. I think this, annoyingly, after all this time crafting this question, I think this is the question you guys have done the best in. So well done you, but I'm not happy. Right, here we go. I will close the poll. And a stonking 84% of you guys have gone for the correct answer, which is urea electrolytes and creatinine kinase levels. What has gone on here in this patient? Let's track through my supposed 4 steps. Why are we doing creatinine kinase levels and using these? What do we think has gone on? AKI? Okay, yes, Prina has traced out those 4 steps. Thank you. So yeah, we think that the brown Coca-Cola coloured urine is very classic for rhabdomyolysis. With the past medical history of MI, they're going to be on a statin. Because they've got a curve score of 4, that means they're going to be put on Comox and Clary. And we know clarithromycin is a potent P450 inhibitor, which can cause your statin levels to spike, and that will give you that will predispose you to rhabdomyolysis. So well done, Sarah and Prina, and well done to the 84% of you who probably just saw the brown coloured urine and went, "Oh, rhabdo." Good. But there's a learning point for you. Yeah, so I'll just trace you those steps. Good. So some people, I think when I did this question last time, a lot of people were opted for blood cultures because they thought, oh, maybe it's a worsening of the infection, or maybe it's post-streptococcal glomerulonephritis or something. But the fact that his shortness of breath has improved suggests that he's clinically improving infection-wise, but something else has happened. So the correct answer is not blood cultures. There we go. Fine. Moving on to aminoglycosides, our big Thor. So we've said that they're an excellent big hitter, but they also have really, really good gram-negative cover. So I think this is a really useful one to know. If you know that there's a gram-negative infection, a lot of people will add on gentamicin or consider having an aminoglycoside. It's sort of the first line, as it were, for big gram-negs. We said it was particularly good for endocarditis because, like we said, it's a bactericidal antibiotic, and as like the Hulk, it has potent side effects, and these ones are your kidneys and your ears, so 2 similarly shaped organs that you have. And as a very small side point, it can cause some neuromuscular blockade, so is in a specific group of patients we would avoid them. Does anyone know which specific group of patients we would not give aminoglycosides to? Thinking about neuromuscular blockade and a certain neurological condition. Very good, Katja. Myasthenia gravis. So in someone who's already got quite a lot of neuromuscular problems with the anti-acetylcholine receptors, further blockade through aminoglycosides is going to worsen that. So you'll want to avoid it in those patients. In terms of thinking about side effects of gentamicin in terms of the ototoxicity, just a side point to ENT. If you're thinking about treatment in otitis externa, that's the reason we would give ciprofloxacin and gentamicin in it, provided the eardrum hasn't burst. If the eardrum has burst, we'd want to avoid gentamicin, although I'm told this is purely theoretical and actually some ENT consultants will give it anyway. But it's just helpful in terms of thinking about the side effects as well.
I was just going to say, so the reason these are so good for endocarditis is because generally, like a lot of their distribution, they'll just end up staying within the blood itself. So you'll see wherever your hospital you're in is often in a lot of the guidelines. Any severe infection, if you're concerned about sepsis, you'll also give a stat dose of gent alongside whatever the normal protocol is, because it's really like the aminoglycosides are just really, really good for infections within the blood itself.
Good. Yeah, fab. The other thing to say is these are also IV only, really. Okay, moving on to tetracyclines. Doxycycline, minocycline, great against the aliens, so your tropical ones, your Lyme disease, that sort of thing. Doxycycline, as Anush has said, is actually used quite a lot and is useful. There are some weird side effects that are useful to know. So I've got a slide with all the with some of the pictures. Can anyone point out what these are demonstrating side effect wise? You don't have to go in order, just describe the photo. Tell me the photo that you're referring to. Okay, we've got teeth staining from use in pregnancy. Very good. So very good discoloration of teeth. So we avoid them in pregnant women and children with growing teeth. Good. That's an important contraindication to know. So that's the bottom left one. Black hairy tongue. Yeah, say what you see, and that is exactly what it's called. Very good. And then finally, top left. I appreciate this is probably one that's slightly less straightforward. Think about what areas has been affected and how it's been. Very good, Sarah. Photosensitivity. Great. So those are the three big common ones of tetracyclines. In terms of black hairy tongue, you tend to see it more in smokers, in people with poor oral hygiene as well, and the management is just scraping it off or better hygiene. Yeah, and important to counsel people on photosensitivity when you start them on tetracyclines. Good. Finally, we've got some DNA synthesis ones and oddballs. These are mostly bactericidal, apart from this sort of one thing that I put underneath. Because if you think about it, if you're stopping DNA synthesis, that's not good for the cell. Trimethoprim by itself is bacteriostatic, so not that useful, which is why when you combine it with sulfamethoxazole, we make cotrimoxazole, which is stronger and is bactericidal, and you might see more. But yes, going on to fluoroquinolones, which we put as the flash, and you'll see why soon. So it's got a fantastic bioavailability. It's super fast. You can give it oral and it basically has the same absorption and same speed of onset as giving it IV. So you very rarely see them given IV. You could just give them orally, and they're a fantastic drug for that reason. It's the only oral anti-pseudomonal agent, and knowing what agents are not knowing which agents target Pseudomonas is really useful, because Pseudomonas has very good intrinsic resistance to lots of antibiotics. Thanks, Anush, for that lovely disclaimer there. And then one side effect that's really important to note is tendon rupture. So thinking about Flash, he needs his tendons a lot, so that's a nice thing to remember. Okay, that's it, and I'm handing over to Anush to tell you about metronidazole.
Just briefly, if you go back for a second, it is also worth noting that almost all Pseudomonas is now resistant to Cipro, especially anything that comes from South Asia, because they just gave everyone Cipro. So it is the only oral anti-Pseudomonal that we really use on a regular basis, if it works. So metronidazole is, it's one of those, again, it's quite good against parasites. It's a bit like it's a bit like the tetracyclines, and it's very good for anaerobic cover, very good against C. diff if it works first line. The important thing is, does anyone know what happens if you drink alcohol while you're on metronidazole, and why? Yeah, it's like the disulfiram reaction, because it basically blocks one of the pathways. So you get the, I can't remember which metabolite you get exactly. One of the finalists probably knows because they're revising for finals.
I think it's the alcohol acetyl dehydrogenase enzyme or something like
that. Yeah. Yeah, Google it. Might be useful for finals. Probably won't be, but Google it while we're mentioning it now. But yeah, really, really good for anaerobic bacteria, though. So in what context in a pneumonia would you think about adding metronidazole? I guess is the important question. We mention pneumonia a lot because, to be honest, it's like the most important infection for exams. Aspiration pneumonia because you have gut bacteria, of which a lot are anaerobic. Exactly. Very good. Yeah, and then back to James.
Going for our lovely Aquaman here for trimethoprim, just because we like to think about water with this. Antifolate as well, think of his lovely green trousers. So its mechanism is to block folate, which is important in bacterial synthesis, but also important for considering interactions with other drugs, which we'll go into. Useful in UTIs if you think about the C. It's first line for lower UTIs. And we've talked about this combination of trimethoprim with sulfamethoxazole to give us cotrimoxazole, which is the first line antibiotic for which cause of pneumonia. It's a less common cause of pneumonia. It's more of a fungal cause. Very good, Pneumocystis urivecii, and we'll talk more about that very shortly. So we've got an SBA, again, more directed for finalists, but if you guys can have a crack at it as fourth years, be my guest. So we've got Penelope Burns, who's a 36-year-old who presents to GP with your very classic UTI symptoms. Which of the following features in her past medical history would make you treat her with trimethoprim instead of nitrofurantoin? I.e., what would be a contraindication for nitrofurantoin?
There is once again an option here that would make me cry.
So I'm going to reiterate the question because I know it's worded poorly. Why are we giving this person trimethoprim instead of nitrofurantoin? So what of the following 5 options is a contraindication for nitro? Oh, this is an even split between quite a few options. Here we go. Can you reveal which option would make you cry before I reveal the answers, Anush? Or after I share the answer?
Would you like to guess?
I'm debating between 2, of which I think everyone else is agreeing because no one's gone for those 2. We'll see in about 10 seconds, I suppose. Well done. Okay, let me share. So stopping the poll. And most of you went for the correct answer, which is CKD stage 3B. I can see why you went for the other 2 most popular ones. So let's go through option number 1. A positive urinary beta HCG recorded today. So i.e. she's pregnant. So in pregnancy, we avoid trimethoprim in the first trimester because trimethoprim, which is an antifolate, is not good for the neural tube. Oh no, 25% of you made you cry. And then we avoid nitrofurantoin in the 3rd trimester of pregnancy because we're worried it might affect the baby who might have G6PD deficiency. So the fact that she's recorded a beta HCG, and I haven't said that she's obviously pregnant, I'm suggesting more early stage pregnancy. So you're fine to give nitrofurantoin in the 1st trimester. No one went for the documented allergy to nitrates. Good. So the actual contraindication for nitrofurantoin is if the eGFR is less than 45. So I rephrased it to CKD stage 3B, which I think a lot of SPAs will try and do. So they'll try and change things to what you're familiar with. So rethink what they mean by each answer option. The reason why I'll talk about on the next slide. And then people, the 25% of people that went for methotrexate for rheumatoid arthritis, that is a contraindication for trimethoprim, not for nitrofurantoin. And that's why I tried to phrase the question again. Which was the answer option that you didn't like?
E.
Oh, fair.
They both have meth in them, which means they're antifolates, which means don't give them together because you'll wreck their bone marrow and then they will have no cells.
These are the contraindications to nitrofurantoin. So I said if the eGFR is less than 45, and that's because you need the kidney to be functioning to actually excrete nitrofurantoin into the tubules for it to get to the bladder and to the urethra where it actually acts. So you need it for that reason. G6PD, so if someone is known to have G6PD, and then also if they're in the 3rd trimester of pregnancy, well, we don't know their G6PD status. I should clarify that's G6PD deficiency. I will change that to the slides in a second. Okay, moving on. This is just a summary slide. I would say just learn the first line for finals and for 4th year exams. The second line ones are a bit more rogue, and I don't think they'll really be testing. I don't think that's particularly high yield. But as Anush alluded to earlier with the cephalosporins, for upper UTIs, you can give cefalexin PO or cefuroxime IV if they can't tolerate taking oral tablets because they're vomiting or something. The reason why nitrofurantoin is not used in upper UTIs is because it's completely filtered by functioning kidneys, so it doesn't stay in the kidney and it can't treat the infection. Moving on to my second, we've talked about this one, so I'll only give you 15 seconds and you guys should all rock this one. Otherwise, I will be sad.
And then Anush will be sad a second time. Or
far, so
third
good.
time. No one made me sad earlier, though, actually, on the first question.
That's really good. I'm surprised there aren't any trolls that are purposely trying to make us sad. That's really good.
I've come after a day of work. Nobody
Oh,
wants
now
to make
someone
me sad.
has. Now someone has. Of course they bloody have. I shouldn't have invited that. Okay, thank you for the person who went for warfarin. But yes, the rest of you were correct, methotrexate. So you don't want 2 antifoliate agents because that will suppress the bone marrow. Before, when I made this question last year, people often thought of sulfasalazine as well because of sulfur methoxazole in cotrimoxazole. Basically, the reason why I've highlighted that in yellow is because it's often linked as well in other type of questions, but it's specifically if someone has an allergic reaction to a sulfur drug, then you might want to be cautious about giving cotrimoxazole, because if someone reacts to the sulfur in a certain type of drug, they might react to a sulfur in this antibiotic as well. But yes, methotrexate is the hard contraindication here. As a bonus, in someone who's just been diagnosed with Pneumocystis jirovecii, what blood test am I going to want to do next? Presuming that they haven't got anything in their medical history apart from what I've put on the slide. Very good. HIV, because Pneumocystis jirovecii is an AIDS-defining illness. Good. Right. So these are some summary slides, but just little useful things that really help for SBAs because, like we said, UCL love to test antibiotic drug reactions. So we've covered a few of them. Oh man, okay. So yeah, match them. Don't worry about any order. Just pop them in the chat, and I will put a disclaimer on one of them because I've since learnt something that is interesting.
It's like one of James's favorite rants. Like he just really wants to rant about it.
I do, but then I catch myself ranting about it and realize how sad I sound. So I've started to reel it in a little bit. But yeah. Oh no, actually, no. I've stayed true to myself in these antibiotics, but I can do a side rant.
We can rant at the end. James can rant at the end to get it off his chest. Because it's been like a whole year.
It's been really hard, Anush. Okay, let me rant. Right. Enough chatter. Let's see if people can put in some side effects with the drugs. You don't have to put them all, but just match them. If you pop them in the chat. Very good. Nitrofurantoin, fantastic. Pulmonary fibrosis. So that tends to be with long-term nitrofurantoin use, not just if we're giving it for 3 days for a UTI. Tendon ruptures of toxin.
Sorry, I was going to say lower lung fibrosis more than upper lobe, if they ever ask, because it's a drug and there's more blood in the bottom half of the lung, so there's more drug going to the bottom half of the lung.
I've never thought of it like that. That's really good. I always just thought heavy things sink down, which
that works for asbestos.
That's true. Very good. We've got tendon rupture for ciprofloxacin, our flash antibiotic. Redman vancomycin, very good. Got a few more going.
Come on, Tim.
Very good. Ampicillin, maculopapular rash. And note, ampicillin and not amoxicillin, and I can rant about that later. Metronidazole, sulfuram, and gentamicin. Yeah, we've covered it all. Well done, team. So yeah, my rant tends to be about this reaction here. You often see in SBA banks and in textbook medicine them doing the same thing with amoxicillin. So someone put on amoxicillin, they developed a rash. What was the actual cause behind the sore throat? EBV. Strictly speaking, it's actually ampicillin, not amoxicillin. and I can rant about that later if anyone actually is interested. On to Anush.
Spot diagnosis, or what's going on with this chest X-ray? Finalists, we've definitely talked about this before. I've shown you this image before 2 years ago.
You can drip feed them history if needed.
No, they don't get history today. Give me a different. How would you describe this chest X-ray, and then what would be your differential diagnosis based on what you're seeing? If there wasn't like 35 of you, I would ask you to go through it. So could this be lung fibrosis? Yeah. So it could be. Apical fibrosis? Yeah. So what are the causes? And so I want you to look at the apices of the lungs, and I want you to tell me if you can see air bronchograms. That's my only counterpoint to that. So air bronchograms, remember, are cross sections of bronchioles passing through an area of consolidation. So you'll see less lucent bits. Can I convince you that there are air bronchograms in the upper lobes?
Do you want a laser point to them?
Oh wait, I can laser point.
I know.
So can I zoom into these slides? So can you see how, like, here, these are cross sections of bronchioles, which look like less, like more lucent circles. So that suggests you've got alveolar tissue that has pus in it, but the bronchioles themselves are clear. So that's a feature of consolidation. So if you're thinking of upper lobe consolidation, what kind of things can cause upper lobe consolidation? So yeah, TB would be on your differential list. What else would be on your differential list? So ankylosing spondylitis would be responsible for the fibrotic changes, but should generally not cause shouldn't cause any consolidation itself. Mycoplasma tends to cause bilateral basal consolidation. But sarcoid again can cause fibrosis in any part of the lung. It tends to be upper lobe, but you wouldn't see consolidation. Klebsiella, so any kind of upper lobe pneumonia should be on your differential list. That being said, bilateral upper lobe consolidation, you should be thinking about tuberculosis. Yeah, sarcoid and TB are often linked because they both cause enlarged hilar lymph nodes, but sarcoid shouldn't, in theory, cause consolidative processes, but in rare cases can, because sarcoid is sarcoid and it can cause anything in the body, but classically no. So TB is the thing you want to think about if you see consolidation. I can see why you're saying it looks fibrotic. I would argue there are probably some fibrotic type changes as well, but the fact that you can see air bronchograms, especially here, is suggestive of a consolidative process. How many ribs are we talking? Yeah, I would argue they are slightly hyperexpanded. Yeah, and the diaphragms are slightly flattened. Okay, so treatment of TB, what are the 4 drugs? Antibiotics. It's like TB is just doesn't. It's kind of separate in terms of what antibiotics you use to everything else. You can't like figure out. You kind of just need to know the antituberculous drugs. Ripe, absolutely. So ripe for 2 months, and then RI for 4 months. As James put it, 4 for 2, then 2 for 4. Notably, initially you're starting with 2 bactericidal agents and 2 bacteriostatic agents, and then after the first 2 months, you basically just move on to bactericidal agents in order to kill off any remnants of the bacteria. So that's basically it for the treatment of TB. What is commonly examined at UCL is the side effects of these medications. So anyone want to give me some side effects for rifampicin? There's one really big one that is quite visible and notable. Oh yes, by the way, yeah, if you need to leave, I know we're overrunning probably by 5 minutes or so. Yeah, discoloration. It's not just urine, it's all secretions actually. Yeah, very good. That's a notable one. And then there's a liver thing that is very important, especially for rifampicin. Oh, that's a good answer, but we're still on rifampicin. But yes, we'll get back to it. Yeah, rifampicin is a P450 inducer. Thrombocytopenia is not that important. It's not going to be examined. I mentioned this for rifampicin because all of the other drugs are actually P450 inhibitors. It's just rifampicin is a much stronger inducer of the P450 system than any of the other ones are inhibitors. So the overall effect of tuberculosis treatment is induction of the P450 system. Yeah, as Sep just said, isoniazid can cause drug-induced lupus, which is a very exciting side effect. But probably, oh, it wasn't him. It was my bad. But what's a more common side effect with isoniazid? That everyone who takes isoniazid will get if they aren't given prophylaxis of it. Peripheral neuropathy, excellent. And what vitamin is depleted that causes this this peripheral neuropathy? Yeah, B6 pyridoxine, very good. So anyone who's starting tuberculosis treatment will be given pyridoxine prophylactic. Whoops, I've shown you already. It doesn't matter. Pyrazinamide is hepatotoxic and causes hyperuricemia. What might a patient then go on to get if they've got a high level of uric acid in their blood? Gout, excellent. And then ethambutol has one specific thing issue again. The clue is, yeah, it can cause optic neuritis. So notably, you need to. Do you know how you investigate someone who started on ethambutol? What baseline investigation would you do if you're worried that they might get optic neuritis? So you're going to do fundoscopy if you're to be thorough, but not quite what I was going for. So the optic neuritis develops over time, so you need to get a baseline. Exactly, you need to get baseline visual acuity, and you also need to get their color vision perception at their baseline as well. And interestingly enough, you monitor this every month after the first 2 months. So the majority of patients that are treated for tuberculosis, you don't need to monitor because they'll stop the ethambutol after 2 months. It's only if they have like complex tuberculosis that you don't need to know about, where they're on it for much longer, that you need to do like monthly monitoring. But basically visual testing is extremely important. And then we'll quickly talk through some cheat sheets for finals. I mean, fourth years, you can look at these as well, but the chances of them coming up are significantly lower. Here are your list of anti-pseudomonal drugs. It's just useful to know because Pseudomonas is very common and is very resistant to lots and lots of things. Cipro is like the only oral option, effectively. And then the other useful lists are anaerobic bacteria and drugs that are against them. This is not an exhaustive list, it's only for exams. Can anyone give me some examples of anaerobic bacteria groups? There's one I basically want you to know off the top of your head. And we'll go over this in a minute.
It begins with the letter C and has already been mentioned in this lecture. Because as a general rule, lots of gut bacteria are anaerobic, but for exams, there's a specific group of anaerobes that is worth knowing about. Anyone? Yeah, so Clostridia are gram-negative, are anaerobic. So that's the group I want you to know about. So anaerobes, Clostridia, Bacillus, Nocardia, Yersinia. Remember Clostridia, and we'll come back to Clostridia in just a minute. Antibiotics that work against anaerobes. We've already mentioned some of these. We just thought we'd put them on one slide. So give me some. Which of the antibiotics did we say have some anaerobic cover or are very good against anaerobic bacteria? I think we mentioned 2 in particular. One which was accidental, one which is very, very good against anaerobes. Metronidazole is like excellent against anaerobic bacteria. Does anyone remember? Yeah, Vanc has some anaerobic cover. It's not. It doesn't work against all anaerobes, but specific anaerobes. It works well against Clostridia. Aminoglycosides less so. That's more gram-negative than anaerobes. So the other one was a penicillin with a beta-lactamase inhibitor. So coamoxiclav or tazocin cover anaerobes very well. Carbopenems, which hit like almost everything because they're just very toxic and very rarely used. And then metronidazole in particular. And then there's 2 more cheat sheets, and then you can we'll finish. Antibiotics that increase the risk of C. diff infection can be remembered by the letter C, but it's not, unfortunately, not every single antibiotic beginning with C, which makes this a less useful way of remembering it. But does anyone know which ones in particular? So as a general rule, things that are broad spectrum are increase your risk of C. diff infections because they kill off all of your normal gut flora. So cephalosporins, coamoxiclav, clindamycin, all of these are true. And all of these are correct. Clindamycin more so. Clary isn't actually associated with that high an increased risk, although it still can. Being on any antibiotics does increase your risk of C. diff to an extent. It's just these are the common culprits. And then the last slide, just because I can't remember the last time I covered this, but I was teaching some people in Liverpool about this the other day, but there are 4 types of Clostridia that you need to know for exams, finals specifically. Again, unlikely to come up in 4th year. Anyone want to give me, so we've talked about one of them, but what are the other types of Clostridial infections that you can get, and what do they cause? If you don't know what I'm talking about, you're going to think, you're going to be very confused. But when I tell you in a minute, it will make sense. Clostridium perfringens causes gas gangrene. Excellent. What else? Clostridium tetani that causes tetanus. Clostridium botulinum is Botox, causes flaccid paralysis. And then we already talked about C. diff, so I'm not going to. Very good. And remember, C. diff can go on to cause like severe colitis, and it can kill people. So C. diff is no joke. I think that is the last slide. So I'm going to stop the recording there. Give us some feedback.